Today's clinician in charge is Professor Shalini Rajaram, and today we have a very interesting case lined up for you all, and with a very catchy topic, serious cancers, a case distillation. I'll now hand over the mic to Dr. Lakhvinder for the case presentation.
Good morning to respected Director Ma'am, Dean Ma'am, esteemed faculty and my dear colleagues. So presenting case of Mrs. X, 62-year-old, parathyroid, postmenopausal woman, homemaker by occupation, educated to 4th class from Chamoli, Uttarakhand. Patient was referred to our Gynae oncology OPD with the ultrasound report showing mitometra, pyometra for further management. She had chief complaint of postmenopausal bleeding and discharge PV since 2 months with loss of appetite, loss of weight. There is no history of pain, abdominal distension, and urinary complaints or altered bowel habits. There was no history of cough, breathlessness, hemoptysis, jaundice, headache, vomiting, or bone pains. Patient was postmenopausal since last 12 years. With the previous cycle was regular average flow. Her perimenopausal transition was smooth. She is parathyroid 1 with all normal deliveries. She is not ligated. Her past history is not significant. There is no family history of pregnancy in last 3 generations. On general physical examination, she has a COG status of 1. There is no pallor or period edema. Thyroid breast was normal. There is no cervical accident by lymphadenopathy. Her vitals were stable. Her BMI was 90.05 kg per meter square. Chest examination within normal limits. On gynecological examination, on per abdomen was soft and non-tender. There was no organomegaly, no mass palpable. There was no ascites. Locally extended area were atrophic. On perspective examination, cervix was atrophic, vagina normal. On per vaginal examination, uterus was retroverted, bulky, diverted to right side. There was a mass felt in the left fornix, 5 into 5 cm size. It was hard and mobile. Right fornix was free and non-tender. She had a 4 into 4 cm mass in the POD was also felt. On PVR examination, rectovaginal septum was free. On per rectal examination, rectal mucosa was free. And the same left addiction and POD mass were felt. So after the history and examination, the clinical summary was a 62-year-old postmenopausal woman with postmenopausal bleeding and discharge per vagina with bulky uterus with peripyometra suggested by ultrasound report outside with left addiction and pouch of Douglas mass likely malignant. Other differential was infectious etiology with bilateral tuberculous masses, chronic tuberculosis, but tuberculosis and acute PID are not very common in the postmenopausal age group. There is senile endometritis with sterile pyometra and pyosappings, which can also occur in the postmenopausal woman. And the last possibility is metastatic tumors to the ovaries from elsewhere, like GI tract or breast.
Any comments from the house at this point in discussion? We'll proceed then. Thank you.
So we did an ultrasound in the OPD which showed uterine cavity distended with the collection of volume 30 cc. So this is the uterus which distended endometrial cavity with ankle collection with multiple capillary growths and endometrial walls present. Patient had a left and mixal mass 5 to 5 cm solid cystic with increased internal vascularity which is ORADS 5. There's another mass of size 4 to 4 cm in the seal in the pouch of Douglas with homogeneous and ecogenic ecotexture. So pyometric drainage was done and abundant nodal tissue was obtained and sample was sent for histological examination. Her routine vascular were within normal limits with serum albumin level of 4.1 and stool for pulmonary negative. Her tumor markers were done. CA125 was raised 571. Other markers were normal. Her chest X-ray, ECG, 2D echo were normal. Mammography and USG breast showed benign findings. Endometrial fluid, the pyometra culture sensitivity was sterile. Pap smear was atrophic pattern and colposcopy showed normal findings. So for the endometrial biopsy report, I would like to call Dr. Dipali as a pathology for discussion.
Good morning, everyone. We received an endometrial aspirate specimen on 18th 123. We received multiple grey white soft tissue pieces. Altogether, they were measuring 1 into 0.8 into 0.5 centimeters and all were processed. On histopathological examination, there was a tumor that was arranged in multiple tissue bits were seen, arranged in papillary and glandular pattern. The tumor cells showed high NC ratio, marked pleomorphism, vesicular to hyperchromatic nuclei, and there was brisk mitosis, as indicated by the yellow arrows. So features were in favor of a poorly differentiated carcinoma. Possibilities were kept as high-grade endometrial carcinoma and serous carcinoma. So to differentiate between the 2 and IHC panel was done. In an IC panel, ER, PR and P40 were done. ER, PR show variable positivity in both the tumors, whereas P40 is positive for high-grade endometrioid carcinomas and comes negative in serous carcinomas. P53 can be wild type or mutated in both the carcinomas. P16 shows patchy positivity in high-grade endometrioid carcinomas and diffuse positivity in serous carcinomas. WT1 is negative in high-grade endometrioid carcinomas, whereas it is positive in serous carcinomas. P10 shows a loss in both the tumors, and HER2 can show a diffuse overexpression in serous carcinomas. So an IHC panel was done in which ER showed strong nuclear positivity in the tumor cells, PR was negative, P40 was negative, P53 showed diffuse loss, and their Ki67 had a high labeling index of more than 50%. WT1 showed strong nuclear positivity. It is considered that WT1 is a marker for serous carcinomas of tubal origin, but according to the study in human pathology, we have seen that 44% of the tumors also express WT1 if they are from the endometrial origin. So based on histomorphology and immunohistochemical findings, a diagnosis of serous carcinoma was suggested.
For the evaluation of the distal and the endometrial pathology, we did see MRI abdomen pelvis for the patient. And for this discussion, I will talk to Dr. Neha, GR Radiology, for the MRI findings.
Good morning, everyone. I'll be discussing the CMRI abdomen and pelvis that we did for this patient. This T2 sagittal images shows that the uterus is bulky with T2 hyperintense content in the uterine cavity. We can also appreciate that there are multiple T2 hypointense lesions. We can also appreciate that there are various T2 hypointense lesions. We will further see that these lesions are showing post-contrast enhancement and also restricting. In this axial T2 images, we can see that there are bilateral solid adnexal lesion. In this section, we can only see the left adnexal lesion. Further, we can see that this is the fallopian tube on the left side. It is dilated. And also, further we will see on the post-contrast images that the wall of this fallopian tube are enhancing. This is the lesion in the pouch of Douglas. This is T2 hyperintense. We can also appreciate another lesion in the endometrial cavity, the T2 hypointense lesions, likely polyp. In this clip, we can see the T2 axial images. We can again appreciate the lesion, the dilated fallopian tube, the lesion in the left adnexa, the lesion in pouch of Douglas, the dilated uterine cavity, as well as multiple T2 hypointense lesions. These are the axial post-contrast images. We can appreciate the enhancement of the lesion in left adnexa, the enhancement of the endometrial lesions, and also the enhancement in the lesion in the recto-uterine pouch. This is the sagittal post-contrast images. We can see that the cervix might be bulky and also showing heterogeneous enhancement, suggesting cervicitis. We can appreciate the relationship of the lesion in the pouch of Douglas, that it is showing loss of fat plane with the uterus and cervix, and posterior with the rectosigmoid, and the left adnexal lesion, which is abutting the posterior bowel loops. We can also appreciate that the peritoneum overlying the rectosigmoid is heterogeneous, is enhancing and nodular. In this post-contrast clip, we'll consolidate the findings. The adnexal lesion on the left side, the enhancing peritoneum, the right adnexal lesion and its relationship, and the distended uterine cavity. We also did a screening of the abdomen. We didn't appreciate any enlarged lymph node, no lesion in the liver. So the impression that was given with bilateral complex adnexal lesions or as 5, pelvic peritoneal deposits with myelosarcitis, and the cervical endometrial heterogeneous enhancement, and also the uterine endometrial lesions, slightly polyp. So these were the findings on radiology. Thank you.
Did you see the ovaries separately? You mentioned it.
So after this investigative workup, the provisional diagnosis we kept was 62-year-old parathyroid with postmenopausal bleeding, with advanced serous carcinoma endometrium, with adnexal involvement, with pelvic peritoneal deposits. Other differentials we kept was a primary ovarian malignancy with metastasis to endometrium, synchronous tumors of the ovary, endometrium and ovary. Other malignancies metastatic to the genital tract.
I invite any comments from the House at this stage in discussion. We'll proceed. Thank you.
So after all the preoperative workup, patient was staging laparotomy on 14th February 2023. Intraoperatively, there was no ascites. Uterus was bulky. This is the uterus anteriorly retracted by the retractor. This is the rectum posteriorly. So patient has 6 to 5 cm solid cystic mass from the left fallopian tube. This is the left fallopian tubal mass. From the fibril end of the fallopian tube, the left ovary was seen normal, separate from this mass. The right tube and right ovary were normal. There was 5 to 4 cm mass in the POD was also seen, which was adherent density to uterus anteriorly and the rectum posteriorly, and small deposit over the right ligament posterior surface was also seen. So procedure done was peritoneal washings from the pouch of Douglas, the paracolic gutters, and the subabdominal area were taken for cytology analysis. It was negative for malignant cells. Peritoneal surfaces, large bowel, small bowel, liver, spleen surface, subabdominal area were inspected and palpated systematically, and they were also found to be normal. Left fallopian tube mass was sent for frozen section biopsy. A type B radical cystectomy with right self-lingophorectomy with left self-injectomy and left oophorectomy was done, along with removal of the POD mass. Systematic pelvic lymphadenectomy was done, supracolligamentectomy was done, and multiple peritoneal biopsies were taken. So peritoneal carcinoma index for the patient was 6 and R0 section was done. There was no resolution left at the end of surgery. So for the frozen and final histology report, I would like to call Dr. Dipali from the pathology.
We received a frozen section on 14th February 23. We received 3 containers. First was the broad ligament deposit. We received 2 grey white soft tissue pieces, altogether measuring 2.5 into 2 into 0.8 centimeters, which were partially processed. POD deposits, we received a single firm soft tissue piece measuring 1 into 1 into 0.5 centimeters, which was partially processed, and left fallopian tube mass. The left fallopian tube mass measured 6.8 into 5 into 3 centimeters. Portion of the fallopian tube measuring 1.5 centimeters could be well appreciated in gross. Outer surface of the tubal mass was bossulated, and fallopian tube at one end was adherent to the mass and could not be separated. The mass was grey, yellow, firm, solid with tiny papillary excrescences noted in a few areas. On microscopy of the frozen section, the mass showed features of poorly differentiated carcinoma. Broad ligament showed tumor cells having similar morphology, and pouch of Douglas showed necrosis. Subsequently, we received specimen for routine processing. We received hysterectomy specimen with bilateral salpingo-oophorectomy, omentum, right and left internal iliac lymph nodes, right and left external iliac lymph nodes, right and left obturator lymph nodes, left and right paracolic gutter. Specimen of uterus with cervix and bilateral ovaries, right fallopian tube and portion of left fallopian tube was received, measuring 12.5 into 8 into 3 centimeters. Right ovary measured 2.5 into 1 into 0.5 centimeters. Left ovary measured 2.4 into 1 into 0.4 centimeters. Right fallopian tube measured 5 centimeters and attached left fallopian tube measured 1 centimeter in length. No solid area was identified. Posterior surface of the cervix and bilateral parametrium showed irregular solid areas. Endometrium showed papillary projections. The largest measured 0.6 centimeters. On histopathology of the permanent sections, the mass revealed tumor arising from the fallopian tube. This is the wall of the fallopian tube and we can see the tumor in the lumen. Tumor exhibited a solid pattern along with slit-like spaces and papillae. It had marked pleomorphism with high NC ratio, vesicular chromatin, and prominent nucleoli. Brisk mitosis was noted as indicated by the red arrows. Sections from the posterior surface of cervix showed tumor deposits. Sections from the uterine wall showed atrophic endometrium with tumor cells confined to the endometrium. Sections taken from the area corresponding to the papillary projections on gross examination showed endometrium showed a foci of tumor nests having cells morphologically similar to the cells of the fallopian tube mass. Tumor islands were limited to the endometrial surface and there was no myometrial invasion seen. Sections from the right in the right ovary and right fallopian tube showed normal histology for age. Sections from the left ovary showed normal histology for age. So immunohistochemical staining was done on sections from the tubal mass as well as from the endometrium to study the nature of the tumor. For both the masses, WT1 showed strong nuclear positivity. Estrogen receptor showed strong nuclear positivity. Tubal mass and endometrial mass showed diffuse loss of p53. HER2/neu was lost in both tubal mass and as well as endometrium. Paxate showed strong nuclear positivity in tubal mass and endometrium. So according to a study, Paxate shows a high expression in serous carcinomas. Other specimens submitted for routine processing were omentum, which was free of tumor. A total of 12 regional lymph nodes were identified, all of which were free of tumor. Broad ligament showed deposits, infiltration by similar cells as fallopian tube mass, and POD showed only necrosis. So we get three possibilities: primary tubal malignancy with metastasis to endometrium and other sites, primary endometrial malignancy with metastasis to fallopian tube and other sites, and synchronous malignancy in endometrium and fallopian tube. So for primary fallopian tube tumor with metastasis to endometrium, points in favor were: on gross examination, we found a larger mass in the tube, which is considered as primary, and the mass was unifocal. On microscopy, there was diffuse involvement of the fallopian tube wall. The tumor was very deep-seated and was seen reaching up to the muscle layer, and on IHC it was Paxate positive. Primary endometrial carcinoma with fallopian tube metastasis, points against, was on gross examination, we found multiple small lesions which were superficial and there was no myometrial invasion. On microscopy, multiple focal tiny lesions were seen adjacent to the atrophic pattern endometrium, whereas in a carcinoma, it is a diffuse process and involves the entire endometrium. On invasion, the tumor was limited to the endometrial surface, whereas there was no myometrial invasion seen, and IHC, Paxate was positive and HER2/neu was negative. For synchronous tumor in endometrium and tube, points for were absence of lymphovascular invasion, and points against were it was a high-grade tumor, it showed no myometrial invasion, and there was involvement of multiple sites. So according to WHO FGT 2020, both the tumors have to be low-grade, there has to be absence of lymphovascular invasion, there has to be minimal myometrial invasion, and there should not be any other sites involved. So we gave a final diagnosis of high-grade serous carcinoma of the left fallopian tube with P staging of P2B, N0MX, and FIGO stage of 2B, with tumor deposits in the endometrium, uterine cervix, that is posterior surface, bilateral parametrium, and broad ligament. Further confirmation can be done by clonality study.
So the final diagnosis was high-grade serous carcinoma of the left fallopian tube with metastasis to endometrium and pelvic peritoneum. The pelvic lymph nodes and omentum was not involved. So the surgical-pathological stage was FIGO stage 2B fallopian tube cancer. So coming to discussion part, as the final diagnosis is a primary fallopian tube carcinoma, it is a rare disease with incidence of 0.36 to 0.41 per 100,000 women per year. And epithelial ovarian cancer is used as an umbrella term for the ovarian, fallopian tube, and primary peritoneal carcinomas because they have extreme similarity in their clinical behavior. So all these three, the treatment approach is same for all, that is surgical debulking and platinum-based chemotherapy without targeted therapy. So there is a hypothesis of the origin of the primary epithelial ovarian, fallopian tube, peritoneal carcinomas from the precursor stick lesions, which are serous tubal epithelial neoplasia, which develop in the female end of the fallopian tube. So most common histology in the ovary, fallopian tube, and peritoneal cancers is the high-grade serous carcinoma. And it originates from the Mullerian epithelium. There is abundant evidence to support the theory that all these carcinomas have extra ovarian, more specifically fallopian cell with the p53 mutation in the fallopian tube at the fibril end. It leads to development of a stick lesion, which is an atypical secretory fallopian tubal epithelium with high proliferative index and p53 mutations. So it may either invade the tubal stroma locally to cause primary fallopian tube carcinoma, which is a rare event. The most common, it may exfoliate to surface of ovary to cause primary ovarian carcinoma, or it may exfoliate to surface of peritoneal surface to form primary peritoneal carcinoma. So there is mutation in the cells at the fallopian tube in the fibril end, and it leads to formation of stick lesion, and it may either exfoliate to ovary surface to form primary ovary carcinoma, it may exfoliate to peritoneal to form peritoneal carcinoma, it may invade tubal stroma locally to form a primary tubal carcinoma. So as that these are rare cancers, the majority of large studies are retrospective. So this is a retrospective study on the primary fallopian tube carcinoma to see the clinical and pathological characteristics of these cancers. The majority of the main symptoms of these are vaginal bleeding and vaginal discharge, which are not seen in the ovarian carcinoma patient, epithelial ovarian carcinoma patient. Other symptoms are abdominal pain in 21%, pelvic mass in 20% of the patient. Most histology has discussed the serous carcinoma in more than 90% of the patient. The most common grade is high grade, grade 3, and the majority, 60% of the tumors are early stages, stage 1 to 2. This is in contrast to ovarian carcinoma, where the more than 70% of patients have an advanced stage, like stage 3 or 4 disease at the time of presentation. So there is a classical Let's-Go type of symptom for fallopian tube carcinoma, which consists of intense profuse vaginal discharge or bleeding, or leaky pain or relieved by discharge, or pelvic abdominal mass. But this type is not specific and reported in 50% of the cases. So it is unlikely to be diagnosed preoperatively due to severity. And 65% of the patients are diagnosed as appendixal mass preoperatively. 23% have as a hydrosalpinx associated with preoperative, and 11% of the patients have coexisting endometrial pathology. So as we kept the initial diagnosis as the primary serous carcinoma endometrium, so this uterine serous carcinoma is also a rare subtype of the endometrial cancer. It accounts for 10% of the uterine carcinomas, but it is a aggressive cancer, accounts for disproportionately more number of deaths. It has propensity for distant metastasis even in the endometrial confined disease, and the 5-year overall survival in the uterine serous carcinoma is 18 to 27%. While the most common variety in the endometrium is the endometrioid carcinoma, which is usually low grade and confined to endometrium and has a favorable prognosis. So for serous carcinoma endometrium, surgery forms the part of initial management for majority of women, either staging for early stage disease or debulking for advanced stage disease. Adjuvant therapy with chemotherapy and radiation is recommended. This is different from the serous carcinoma, primary carcinoma of the ovary and the fallopian tube, where adjuvant therapy is only chemotherapy. So due to high prevalence of HER2 overexpression in these serous carcinoma of the endometrium, testing for HER2 should be considered in women with the uterine serous carcinoma, and this is diagnostic as well as therapeutic also, because trastuzumab can be added to those patients who have this biomarker. A novel combination of immune checkpoint inhibitors with the targeted therapies are under evaluation for these cancers. So these uterine serous carcinoma has a propensity for accidental spread even when they are confined to the endometrium. So this was a retrospective study on the patient with the uterine serous carcinoma who had a non-invasive endometrial confined disease. And out of 33 patients, 13 patients who had a uterine confined endometrial confined disease. 13 patients were found to have a disease beyond the uterine final histopathology, with the most common sites of metastasis being omentum and adnexa. So other differential we kept in the initial was synchronous tumors of the endometrium and ovary. They are also known to occur in the endometrium and ovary. So this was also a large retrospective observational study. They evaluated the year database between 1973 to 2013. So 2,30,454 women with the primary endometrial cancer and 1,10,000 women with the primary epithelial cancer was studied. Cancer, synchronous ovary cancer was seen in 1% of the patient, and in patients with endometrial primary ovarian carcinoma, synchronous endometrial cancer was seen in 3.6% of the patient. And the most common tumor at both sides was endometrioid tumor, that is present in around half the patients. So synchronous tumors, they are usually occur in the peak incidence in late 40s and 5th decade. Thereafter they decrease significantly. Majority of synchronous tumor and endometrium ovary are early stage and low grade endometrioid type. So these 2 points were against our case, and they are more likely to occur in patients with Lynch syndrome. So genetic testing is recommended in women with the synchronous endometrium ovarian cancers. So in various studies, the rate of synchronous tumor in the endometrium ovary has been reported from 3 to 10%, but it's difficult to differentiate between these two at a dual primary, that is synchronous or metastatic cancer. So genetic analysis with using NGS for genetic studies can be more accurate for evaluating these cancers. In non-endometrial histology and high flow grade, which was in our case, they are mostly observed in metastatic cancers. And other differential in the initial period was metastatic tumors to the genital tract. Ovary is the most common site of distant metastasis from outside within the gynecological tract. 3 to 20% of patients of the cancers of the ovary can be of metastatic origin, and the most common primary sites being GI tract from the colorectum or stomach, breast cancer or pancreatic biliary cancer, while metastasis to the endometrium are rare, around 3%. So after the final diagnosis of fallopian tube cancer, the further management is on the same line as the primary ovarian carcinoma. That is, adjuvant chemotherapy with pancreatic carcinoma is given every 3 weekly for 6 cycles post surgery. And after completion of treatment, the follow-up is every 3 monthly initially for the initial 2 years, then 6 monthly for the next 3 years, thereafter annually. And at each visit, clinical history and examination with CM125 levels were done. And immediately CT scan or PET CT is done at suspicion of either clinical or biochemical relapse. So for our patient, we also referred the patient to medical oncology for adjuvant chemotherapy after surgery. So patient was planned for 6 cycles of chemotherapy with pancreatic carboplatin every 3 weekly. And patient received 3 cycles of chemotherapy till now, last of 29th April 2023, uneventfully. So this is the timeline of events. Patient presented to first to our OPD on 16th January 2023, and the endometrial biopsy was done in the same visit. Its report came on 20th January. Then CMRE was done on 23rd January 2023. Thereafter, the endometrial biopsy ILC report came on 8th February. And patient was operated on 14th February 2023. Then the final histology report came on 6th March 2023, and the patient was started on chemotherapy from 14th March 2023. So we usually try to do the management for the patient with cancers within 4 to 6 weeks of their presentation. Thank you.